tasked with, at some point, being a lead technologist. You might be tasked with being a QA technologist or doing some of the QA tasks. I guarantee most of you, if you get a job at Kaiser and you're working nights, I guarantee you're going to be doing the weekly fluoro test. Anyway, so let's just talk about some basic quality assurance issues. First of all, is to realize what's the difference between quality control and quality assurance. People tend to use these terms interchangeably, and they're very, very different. Quality control is a system of routine technical activities to measure and control the quality of a process, a single process. Quality assurance is the planned system of evaluating the quality of a process through evaluation and review of quality control data. So you perform quality control tests, and the results of those tests, when taken together, become the results of your quality assurance program. State of California and Joint Commission, as well as if you are part of a program accredited by the American College of Radiology, all of those programs require that you have a documented quality assurance program, and that you can show that it's not only documented, but you actually have test results, and you can document that those are evaluated on some regular basis. The appropriate place for these generally to be evaluated is through the Radiation Safety Committee at your facility, but other facilities, they do things sometimes through a quality committee, sometimes through the administrative committee for the department. It's different, but in a lot of places it goes through the Radiation Safety Committee, because quality assurance program results are usually reflected in patient data, patient dose data, patient retake data, those types of things. Okay. So the program, if you look at it as a box, I mean, it's pretty simple. You start with your technique, and however you adjust the X-ray generator drives the tube, exposing the patient, hits an image receptor of some sort, you have a readout, you have a display, and then there's the observer. So this is kind of all behind the curtain, if you will. You have technique, and this is what the radiology sees. Okay. So each one of these processes, you can have different tests that control each one of these particular boxes, and those can be evaluated on some basis. Regulatory requirement, this is from the feds, radiation protection programs. Each licensee shall develop, document, and implement a radiation protection program commensurate with the scope and extent of licensed activities sufficient to ensure compliance with the provisions of this part. The way this has all been interpreted and how the state of California has incorporated this into their regulations, radiation protection program is all-encompassing and includes any quality assurance or quality control tests that affect patient exposure. So that means anything that deals with image quality, equipment performance, all of that is part of your radiation protection program. State of California, this is the one that says for equipment manufactured after a certain date, very old date, user shall provide sufficient maintenance to keep the equipment in compliance with all applicable radiation protection sections of CFR 21, 10, 20, 30, 31, and 32. This is something when Joint Commission or State of California, any regulatory agency comes through to look at, this is where your service department, or if you contract with outside service, your vendor, for example, that you need to document that sufficient maintenance is performed. Now, what does that mean? A lot of folks is like, yeah, well, when it breaks down, we get it fixed. That's not acceptable. The manufacturer and the documentation that comes with the equipment gives you a whole section on what their recommended maintenance program is, as far as routine maintenance and all of that. Even though it's recommended, the regulatory agencies look at that and say, if you're not going to follow what the manufacturer says, you have to show us just cause why not. Otherwise, your quality control and quality assurance program had better, for your equipment, had better include all of those. So for quality control, you need procedures that are used to test and maintain equipment. That would be acceptance testing. Joint Commission requires that every piece of medical imaging equipment, before it's ever used on a patient, when it's first purchased, or if it's rented or leased, or anything that comes in for the first time use, has to have some sort of acceptance testing done. Joint Commission requires that to be done by a board certified or some other certified medical physicist. And that establishes baseline performance. So everything in the future will go back and refer to, this is how that equipment operated at the time it was purchased or first acquired, and everything goes back to that to determine how performance either improves or degrades and what happens. Maintenance, you have preventive or unscheduled. Unscheduled, that's what it's called when something breaks.
Bless you.
And that includes everything, even down to the fact that your collimator light goes out. That's an unscheduled maintenance. Preventive is usually, there's things that are done annually, quarterly, and semi-annually, and that's either performed again by the vendor, or if you have in-house service, some of those they're going to perform. There's also annual testing that medical physics has to do for particular pieces of equipment. If there's a problem, then there also has to be verification testing showing that it's been corrected and that it's done by a person that's recognized by the accrediting agencies or ACR, if you're through one of their programs, can do. Don't read all of it. The important part of this says that currently, 30307B2 for state of California says, for equipment that uses automatic exposure control, which is everything that you use now, there is no manual control anymore. Those units are all old. But for automatic exposure control, there is a requirement that once a week, you test it with an appropriate phantom and look at tube current and potential and make sure that that doesn't change the patient exposure by more than 25%. So the standard for California is 9 7/8 inches of lucite, or 7 7/8 inches of lucite. You can use anything that's close to that. You can use water, which is a pain. It spills. Lucite's easy, it's heavy. A lot of facilities have something basic. I know at Kaiser, it's a steel plate with a rubber backing, and it's enough to basically drive equipment to a certain point. You put that in the beam under specified settings of generator, and you step on the fluoro pedal, and you monitor MA, displayed MA, and KV, and that goes on a chart or a graph. Now, the interesting part about this, where it says if it's going to change the patient X-ray exposure rate by more than 25%, MA is what? MA is easy. If you double the MA, you double the exposure. Okay? So there's a direct correspondence. KV is not that. Now, there's a lot of things depending on what KV it is. It could be KV squared, or to the power 2.1. It could be to the power 1.5. That makes it a little difficult to do that. But that's what physicists get to do. They'll plot a chart or a graph, and you just mark where your MA and KV is, and it's either within the error bars or it's not. If it's outside of the error bars, state of California says you can no longer use that piece of equipment. It has to stop. So for those of you who work at Kaiser, the test is called green plate, because that's what it is. It's colored green. If it fails that test, you have to report that to your supervisor. That goes to service, and they have to fix it before it can be used on a patient. Wherever facility that you work at, There will be weekly fluoro checks. What they use and how they do it, you're going to have to check with the facility that you ultimately work at. But that is a state requirement. Okay. Records have to be kept for 3 years. Guarantee you when an inspector walks in, they're going to ask for those. And they're going to expect to see them every week. Most facilities, what they do is they have the nighttime tech do it because there's very, very little to do. And in many facilities, even though there's equipment in surgery and orthopedics and the cast room and the ER and other places, a lot of hospitals look at it and say radiology is responsible for all of it. So that's what the night tech in many places gets to do, is they get to go do the weekly checks everywhere. So, but that's a state requirement. Simple test to do. Measurements with tabletop exposure rate have to be done at least once a year, and any time that a major component is changed out. So obviously, if you change out the X-ray tube, things are going to change. If you change out any of the exposure board, exposure controls, the imaging assembly, power source, any of those changes that is going to change the output that the patient sees, tabletop exposure has to be made again. Ignore this. Cine radiography equipment doesn't exist, but there is Cine on our digital equipment. State of California has determined that anything over 15 frames per second or more is considered Cine. On older machines, there actually was a button. There was a button and it activated the Cine camera, and it ran 30 or 60 frames per second on 35mm film. That's old technology, it doesn't exist. When we moved to digital, there were arguments with the state. They said, well, you're using pulses, so anything over 15 pulses. And it's like they had to understand the difference between pulsed exposure and angiographic exposure, where you're actually doing frames, not pulses. It took a long time, but they finally agreed 15 frames per second or above is considered Cine. So if your equipment is capable of doing that, then you also have to measure tabletop exposure at those rates. SMPTE. This is an important test pattern. For the digital world, the display of contrast that matches what your eye can perceive is extremely important. Radiologists are the ultimate judge of that. So the Society of Motion Picture Technologists and Engineers came up with a pattern that was used and is still used in television and movies and everything else. Even though it's back in 1983, this pattern is still the standard by which displays are judged. So when you're looking at this on your display, there's a couple of things. You should look at the transition between white and black and white. It should be clear and crisp. It shouldn't be smudged. The squares should actually look like squares. On a typical II type system, this is where you would see your pin cushion distortion perhaps, if you're using a phantom that you're actually imaging. Generally, these reside in the computer, so you're only looking at the display. Okay? And this should look like a square. And on my computer, it looks like a square. Here, it looks like a rectangle. So obviously, this would not meet the requirements. It would be out of spec. For contrast, there's the 95 and 100% contrast going from white, grayscale, all the way to black. And there's also a 0.5% there, which up close you can't see. And from back here, you can't really see either. So this would be compliant. This would not be. So there would have to be a recalibration of the monitor done to make sure that the 0.5% box display was visible. And then you've got low contrast and high contrast resolution patterns that can be done. Many vendors have automated software that's already preloaded on the equipment to evaluate whether this is compliant or not. There's also software that allows you to use this to calibrate your display. This is something that, personally, this is what, every time the physician boots up their computer in the morning, their display computer, this is what they should come up. It'll take them less than 5 seconds to scan this. If you've ever watched a radiologist read film, they're extremely fast. They use, their eyes do a raster, and they can pick out whether contrast is what it's supposed to be, the shape, all of that, and then they would go on and read their films. They would indicate that yes, this is acceptable, or no, it's not. If they answered no, then it would have to be recalibrated. Now, everybody says, well, we don't process film anymore. That's true. But in the digital environment, it is necessary to produce digital copies. When I was still working, I don't think it's changed. It was very clear the legal system does not accept digital versions of images because they feel they can be doctored, they can be changed. They want, for court, they want hard copy digital images. So that requires that you have a digital printer, not a film processor, but a digital printer. And you can use, like we used to do, a sensitometer like we did on film and actually plot these, I can't go backward, there we go, and actually plot these on a graph and see what those look like. So you would, so on film, remember, in film you get this typical H&D curve. But for a calibrated digital display, this should be a straight line. So, this is a sample. This is a linearity validation of a Kodak CR and a Hawk DR2 print calibration. So this is off a digital printer. So if you measured those steps that I indicated, this is what you should get. This is sure to be green. This is what you want, linear. These are your error bars, okay, the red. And this is what your actual result is. So this, obviously, the system is out of calibration, which means you're not displaying contrast levels accurately. The whole idea behind the digital image standard, DICOM, is that regardless of where you view an image, whether it's on a monitor or in the room or on a piece of film or on a physician's workstation, the contrast levels should appear the same. So you're not getting any distortion there. So obviously you'd have to recalibrate this, and with recalibration of the display, now you've got your measured densities are well within the error bars, and it's good to go. This is especially important for mammography. It's a required test that the feds require if you're going to be certified to do mammo. Half-value layer is another important test. That's really kind of easy. You just start out with a detector and a standard exposure, and you keep adding successive amounts of aluminum in this case, and you can determine what the half-value layer is for the X-ray. Now, that's an approximation. You have to remember, half-value layer is defined only for monoenergetic radiation. X-ray being not monoenergetic, but polyenergetic, means as soon as you start putting aluminum in, what happens? What happens to your? It
hardens it.
It hardens it. So that starts what? Shifting the curve to the right slightly, not a lot, but ultimately if you start getting enough, yeah, it will shift a little bit. The error is enough that we still call it half value liquid. Okay? But that is the standard way to measure. Okay? Different ways of doing it. So in a C-arm system, typically, I don't like this diagram, but the requirement is at 30 cm from the image input of the image intensifiers where you measure. This is where your 7 7/8 inches of lucite would go. Typically in real life, we flip this upside down. We put the lucite here, and it's actually a 30 centimeter thick block, and you measure like that. It's a lot easier than trying to balance something on a tube port. But that's how it is on that. For a standard RF room like we have in the back, it's tabletop. The problem here is no detector actually lies flat. So what do you have to do? There's all sorts of fun. Even though this distance from the chamber to the tabletop is only about 2 centimeters, you have to inverse square it. And you think, it's ridiculous. It's not that different. It's true, it's not that different. However, when your regulatory inspector comes in, that's what they do, and you can be compliant here, but as soon as they inverse square it, you could be 1/10 of an R off, and they're going to cite you for it. That's just the way they work. They're crazy folks. Over table X-ray tubes, it's a lot easier. It's 30 cm above tabletop, and that drives with 7 7/8 inches of lucite in the beam. Simple to do, has to be done at least once a year, or anytime after things are changed significantly. Retake. This is one of the heartburns that a lot of students have about retake analysis. This is really dependent on management and how they frame this. For example, when I set up retake analysis at one of the facilities that I consulted with, I explained to them that you have a choice. You can do it by room, and if you have multiple technologists working in the room, any errors basically are reflected among that entire group. Or you can do it by technologist. For mammography, we ended up doing it for per technologist from a retake rate, but it was 0 risk. So there was no downside for the technologist being identified with their retake rate. What it was an opportunity for either retraining or having someone come in and view the procedure and see where things can be improved. So it was an educational opportunity. As long as retake analysis is used as a carrot and not a stick, it is very, very valuable. The problem with the digital world, as you know when you're out in the field, is unless you have software inherent in the DR or the CR system that you're using, you could come in for a chest x-ray and I could do 10 x-rays on you. And I'll say, I'm going to keep this one, I'm going to keep this one, and all the rest of them go away. Unless the system does not allow that, unless there's some hard stops in there, then your retake rate is meaningless. Most systems will capture all of those. You'll choose the ones you want to send to the physician, but the ones you don't choose are still kept in a database so that a retake rate for that particular procedure or room or technologist can be calculated. That's how it's supposed to be. So that's something to be aware of. I think it's important to do, but you want to make sure that your program is using it as a carrot and an opportunity for improvement rather than a stick. Anyway, so this is a plot for HDL. So you've got relative exposure as a percent. You've got thickness. This is on a standard scale. Notice this is kind of a curve. When you put it on a log and you get kind of a straight line, you still get these slight differences from a straight line, and it has to do with hardening. So it's very, very minor. But that's how you would plot HDL. Resolution limits are something that needs to be checked, usually at acceptance, or if the II is changed out. Remember, II is age, so every year an image intensifier that's under normal use in a hospital is going to age and lose gain of about 10% a year. So at some point, what happens? Oh, and as gain goes down, what happens? What do you have to do? What does the system do?
Increase technical factors.
It increases your automatic brightness system, so it's pumping out more X-ray to keep that image the way it's supposed to. At some point, that's going to lead to what? A failure of your weekly fluorocheck test, because it's going to go outside the bounds because the gain has decreased so much, the equipment's pumping out a lot more exposure, you reach that 25% point, it's like, oops. So now you require recalibration by the engineer to bring it back into spec. Anyway, so for different types of IIs, the typical resolution limit, line pairs per millimeter, is about 2 or less. As you go up in magnification, you can get some better resolutions. This is on, also you have to be aware this is for 512 by 512 pixel. Lots of different ways you can test. The labs we're going to do here is we're going to be using this particular test tool, which has different sections of, actually it's copper screen that you just cut and you put through between 2 pieces of plastic, and you image that and you count the number that you can see. Can you see 40 lines per inch? Can you see 24? For the system in the back, you're going to be looking at both center and at the edges. They will be different. You also want to check to see, is it clear in the horizontal direction but blurry in the vertical, or vice versa. That's important to know. You've got more complicated patterns. You can put things in that have copper mesh to look at sharpness. You've got resolution patterns that actually measure line pair resolution. You've got indications for where your fluoro shutter should be. You can have low contrast and high contrast input. Phantoms come in all sorts of shapes and designs and expenses. Major artifact that we get in image intensifier is pin cushion, which is on the left. The other one, not so much now, but in some of the less expensive units, unless they're shielded, if you get a piece of metal close to this, or you're in a magnetic field, you'll get this S-shaped distortion. The way we used to test for it is we would just take a screwdriver and lay it on the top of the image intensifier, and you would see this basically wavy screwdriver. And that meant that basically what you had was an image intensifier that was not shielded magnetically, and that went back to the factory or got replaced. Those are important to look for. This is a particular phantom. It lets you do lots of things. One phantom lets you measure entered skin dose, minimum detectable contrast, low contrast resolution, optical density, high contrast resolution. High contrast resolution is done with a metal phantom. Low contrast resolution is done with usually tissue equivalent material. It can include things like paraffin. It can include things of different differing contrast. There's some let you know, you can figure out what the minimum detectable contrast is. That's important. If the minimum detectable contrast on a system is poor, then for studies that you need the ability to see low contrast structures, that system's not a good one to use. Phantoms can run very, very expensive. This is a special cardiac phantom that has a line pair phantom here. It has different contrast patterns. It has some artificial layers that have contrast-filled catheters of different sizes. Allows you to look at field of view. They're crazy. Lots of different designs. So for computed and digital, so limiting spatial resolution for high contrast objects are independent of dose, whereas limiting contrast resolution of low contrast objects are strongly affected by dose. So here's a noiseless, which means a very high dose image. So you can see that going from right to left, the sizes get smaller, and going from top down is the level of contrast lessens. Okay, so your higher contrast is along the top, your lower contrast is down here. If your image is really noisy, then you evaluate it, and you can actually look at then what your limiting resolution is, whether it's the higher dose and the lower dose. Limiting contrast is down here. And these are all important characteristics, especially in angiographic and special procedures room, where contrast is very, very important. It's also very important in CT. So for low contrast performance, for what we're doing here, it's a phantom of 2 rows of equally sized and shaped holes. Both holes of the same size should be seen in order to count them as one hole set. For the phantom here, it goes, the top set goes large to small, and then below that it goes small to large. All fluoroscopic systems should image, for this one, the 2 largest holes clearly. The 3rd largest should just be barely visible. The recommendation is that be performed semi-annually. Generally, it's only performed at acceptance and during the annual check. There we go. Digital radiography there's also some checks you can do. So you've got, here's the problem with digital. For screen film, as represented above here, if you overexpose the patient, it's obvious. Okay? This is what you're supposed to have. These are grossly overexposed. But on a digital system where contrast can be artificially manipulated, you can take an inherently insufficient exposure and make it look okay visually, or overdose by quite a considerable amount. You have no idea. Now, you're supposed to be looking at the numbers, so whether it's the contrast index or whatever system that you're using, the identifier that they use, you can use that to see if that's out of range. But in testing, you also want to see what it actually looks like, because at some point, when you're trying to establish a new technique or a new procedure, you can't do it on patients. Okay? You can't make patients your test phantom. You need to use phantoms to determine at what point do we get sufficient low contrast visibility that's acceptable without overdosing patients. And that's what phantoms in your quality assurance program can do. It can give you a starting point for new procedures, or a way to evaluate if your current performance is what it's supposed to be. Phantoms, you can see you've got bone equivalent material here for different thicknesses. And so you've got different contrast levels and looking at tissue versus bone or fake bone. There's many things that you can look at. You can also look at the ability to see contrast-filled catheters. So you can do phantoms to check how well subtraction works. So you've got logarithmic conversion or no logarithmic conversion. What can you see? I think this is a 1 millimeter catheter with an iodine solution in it. So there's lots of things you can look at to determine if the system is going to show you and demonstrate for you what you need to see. Phantoms, this is just a way to show that you can use a phantom to determine if linear subtraction versus logarithmic subtraction is better. Lots of different analysis you can use. The effective quantum model, still have issues with. That's one of the things about digital is a lot of people, it's like, oh, I think there's too much model or it's too noisy. So they start upping their numbers when the amount of model or the amount of noise for a particular procedure that they're doing is fine. It's still diagnostic, but it may not be visually pleasing to either the technologist or the physician. Okay, so you can test and see quantum models of function of exposure. In this case, again, for iodine-filled catheter. And then you can do the same thing overlying a different tissue contrast. So image processing assumes properly calibrated acquisition and display. That's important. Miscalibration of either acquisition or display can seriously degrade image quality. Degradation cannot and should not be corrected by changes in image processing parameter. This is one of the issues with ultrasound, and it was really difficult in the beginning to get technologists to follow imaging protocol, because on ultrasound equipment you can manipulate the visual display with contrast and brightness controls, and they would look at that, it would look perfect to them, but then they go to print it and it didn't look anything like what they had there. It was because they were manipulating this and not the system. And so it's really important that your system is calibrated. So what you see on the screen and what comes out of the printer or what comes up on the physician workstation looks the same. Okay. Display calibration is a critically important component of quality assurance for any digital radiography or fluoroscopy system. And it helps to have a keyboard that works. Okay. So, and here's what can happen. If you look at just this image here, you think patient's got pneumonia, right? Doesn't that look like a pretty pneumonia film? It's like, you got some stuff in here. But it's not calibrated. It's way miscalibrated. But once it's calibrated, there's the same image. It's a normal chest. So it's really important that that's calibrated. We don't worry about CRTs anymore. I don't think anybody is using CRTs anymore, which is, it's good and not good. The advantage to CRTs